Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the FIA Group.
Welcome to another episode of Empowering Plans by the FIA Group. My name is Cindy Merrell. I'm an attorney here at the FIA Group, and I'm joined today with Micah Iberosi-Parnell, another attorney. Micah, it's my first time being able to record with you today, and I was hoping that you could tell me a little bit more about what you do here at the FIA Group.
Yeah, thank you so much for that lovely intro. I am an attorney in the PGC group where we provide compliance and regulatory advice for our client plans. And yeah, I'm eager to be here.
Wonderful. So today we are talking something that is near and dear to one of our leaders, Ron Peck's heart. We are talking today about insulin, and I would encourage everyone to check out Ron's article on the FIA Group's blog discussing his personal experience with type 1 diabetes. I wanted to bring in something today that I have also had some personal experience as a person who loves and supports another type 1 diabetic, my friend Meredith. She was a roommate of mine in law school, and I didn't know much about diabetes until one day I came home from school and she was in the throes of ketoacidosis, which was very scary, and I had to take her to the hospital where I began my education on all of the things that a type 1 diabetic needs in order to be able to survive on a day-to-day basis. One of those very vital things, the most vital, is insulin, and that's what we're here to talk about today. A study from BMJ Global Health in 2018, they were studying the cost of manufacturing human insulin. And what they found was that the human insulin cost $2.28 to $3.42 to manufacture, and analog insulin costs about $3.69 to $6.16 to manufacture. Now, that doesn't include any of the cost administration, the sales, or the research and development, which obviously we do agree that there should be, some kind of compensation for that. However, the problem being is that once it's manufactured for that cost, what caps at $6.16, it's coming to your pharmacy and selling to you retail anywhere between $175 and $300. So what does that mean for plans, and what does that mean for patients, Micah?
Yeah, and it still ultimately means that there is massive burden on both plans and patients, especially in terms of insulin rationing due to the cost. On average, you see about 3 to 4 people die actually from rationing their insulin each year. And it increases plan costs, it increases patient cost sharing. There's not really a good effect from it. And that's what Congress is trying to address in these new bills, or at least they say they're trying to address in these new bills. The weirdest part about insulin's high cost is it's basically a generic drug. There's no patent on it like you would get with a specialty drug, like you get with higher cost chronic conditions like arthritis and Alzheimer's. Instead, it is what's known as a biologic, where they have to grow it. So there's a little bit of a manufacturing expense, but a lot of it is just drug companies increasing their bottom line. Congress has chosen to tackle this as their bipartisan effort on drug reform. They basically separated it from Biden's, hold on, let me get this alliteration right, Build Back Better bill. There are a couple competing proposals on limit cost for patients and address the insulin expense problem, but not all proposals are created equal. The biggest right now, the proposal that has the most steam in Congress is the one that recently passed in the House and is now up for debate in the Senate, which is called the Affordable Insulin Now Act. And the gist of it is that it proposes to limit participant cost sharing for insulin, a 30-day supply of insulin, at $35 a month. This would apply to governmental plans along with employer plans, self-insured ERISA plans too. And interestingly, it's not a coverage mandate. So employers don't have to cover insulin, but if they do, they have to limit the costs to $35 a month out of pocket. Weirdly, it doesn't actually address the underlying retail price, which would still be the average of $175 to $300 a month. So uninsured patients, anybody that has to purchase it outside of insurance would not be able to even qualify for that protection, or anybody whose employer doesn't even cover it. So there's a lot that these proposals lack. Interestingly, there is another proposal in Congress, or at least there was in the Senate, from Senator Raphael Warnock. And he's also sponsoring the one that just passed in Congress that's limiting cost sharing. But his initial proposal was to actually cap the price, which from a cost expense standpoint would be a lot more effective. Because the other issue with just capping cost sharing, aside from a patient perspective, let alone from the plan's perspective, is it really does nothing to actually address overall health spending on insulin. Because say an employer implements the $35 a month cost sharing, but then they have to increase their deductible because now they have to compensate for these adjusted costs or increase their premiums. Either way, it makes insurance less accessible, less affordable for patients. And there are insulin advocates talking about this from both the uninsured perspective and the employer perspective, because shifting the costs onto plans at the end of the day doesn't actually solve the problem. It kind of just gives you a little feather in the cap if you're a congressperson, to be able to go to your constituents in the midterms and say, hey, I did this, even if they never actually feel the effects of it.
It seems to me that it's a very one-sided approach. It's not a very comprehensive approach. It sounds like to me all they're doing is being able to go back to their constituents, you're right, and say, well, I got you $35 cap, but they forget to mention that your premiums and copays and deductibles may all increase as well.
Completely. And from the financial perspective, I remember seeing a stat that basically like 60% of Americans, including those with employer health insurance, still have to pay over $1,000 on average out of pocket. And this would pretty much just continue that trend where employers are having to compensate the costs in the other way. It's like if you were to go into McDonald's, order a burger and a Coke, and they charge $1 for the Coke and $10 for the burger. And then you're like, whoa, I'm not going to pay $10 for this burger. That's ridiculous. So instead they say, okay, $5 for the burger and $6 for the Coke. And then it's essentially saying, sure, fine. You're just shifting the cost to something else that makes it a little bit harder for the end user to spot. But from the employers, from the patient's perspective, from an actual outcomes perspective, it doesn't actually help anything. And like you said, it's very one-sided, and it just seems a way to say you're doing something without actually challenging the costs and challenging the pharmaceutical industry on their price gouging, really.
So I believe that 3 manufacturers hold 95% of the insulin market share. It's curious to me that we aren't looking more at that concern as opposed to coming up with a cost sharing cap. And I would hope that maybe that's something that can come out of all of this.
Yeah, I would hope so too. And I think that's something that if any employer is seriously concerned about this, they may want to phone their congressman and voice support for an overall price cap as opposed to a cost sharing cap, which won't help their bottom line at all. It will possibly even just continue to increase their health expenses. A big reason for this is, interestingly, all the proposals for price capping and limiting the costs, whether through cost sharing or PBMs or any different way you want to look at the situation on limiting the cost of insulin for patients, it is all coming from Democrats. But it seems like the proposal to limit cost sharing has been honed in on as a way to get the most bipartisan support, because especially as of late, pharma has been pouring a lot of donation money into some very popular Republican senators. And this would probably be a way to be able to sway their support to pass a bill right away. And Chuck Schumer, the majority leader in the Senate, has said that he really wants to hold a vote by the end of April to get this legislation passed. It seems to be a big priority before the midterms for Democrats. And this will be putting the mechanism on plans as opposed to an overall price cap that would affect pharma's bottom line seems to be a better way to ensure that that will happen now and get that bipartisan support that Democrats are looking for. It seems like this is becoming a political stunt to an extent of getting points on the scoreboard for DC, as opposed to a way to actually address health costs and the impact of insulin.
Ultimately transferring those costs back to the patients through, as we discussed, through copays, premiums, and deductibles. We're talking a lot of doom and gloom here, though, so I'm trying to find, I always like a silver lining in this, and something that I can say that I would hope that maybe if the patients have more affordable access to insulin, maybe that will prevent future complications because they don't have that, such as my roommate in law school who went into ketoacidosis. So we're helping plans navigate all of this. Hopefully there will be some cost savings because they won't have as many ER visits and those complications down the line. So hopefully we can see some kind of benefit from this.
I appreciate you making sure that I don't end this on a doomsday note. I can be the doom and gloom guy and you can be the sunshine. I think that is a good kind of ending point to take it away on, because anytime patients can access not preventative medication, but medication that can help manage conditions, a month's supply of insulin is cheaper than amputating a foot because of diabetes.
Ultimately can be more affordable if there was, we hope, a more comprehensive approach taken to this legislation.
Yeah, and prevention and management is always cheaper than catastrophic and acute care. And that would be the silver lining of any insulin measure. Obviously, overall, we definitely want a more comprehensive bill, and we'd like to see a price cap as opposed to just a Band-Aid on cost sharing, which would ultimately be more effective for patients and plans. But yeah, hopefully Congress will get some sense, but if not, it will at least be a win in terms of access for patients.
Let's hope so. Let's hope we can see something that will improve from this problem. Well, I appreciate you and your time and letting us know more about what's pending currently and where we might be going. And we look forward to talking to you again with the FIA group and empowering plans. Thank you.